everybody, and welcome back to my channel. And today we're going to be talking about bipolar disorder and how to support individuals who have bipolar disorder. So yeah, it's a really important video that I wanted to touch on and do because I have individuals that I'm friends with who do have bipolar disorder, and I wanted to do this video as awareness and just to kind of get the message out there that you don't have to stereotype people with bipolar. They are very different. There is two types. There's bipolar type 1 and type 2, which I'll link down in the video description below if you want to read more about what it actually is for bipolar. And it says on Wikipedia that I've got here, bipolar disorder, previously known as manic depression, is a mental disorder characterized by periods of depression and abnormally elevated moods. If the elevated mood is severe or associated with psychosis, it is called mania. If it is less severe, it is called hypomania. During mania, an individual behaves or feels abnormally energetic, happy, or irritable. Individuals can often make impulsive decisions with little regard for the consequence. There is usually a reduced need for sleep during manic phases. During periods of depression, individuals may experience crying, a negative outlook on life, poor eye contact with others. The risk of suicide is high. Over a period of 20 years, 6% of people die by suicide, while 30 to 40% engaged in self-harm. Other mental health issues can include anxiety disorders. Substance abuse disorders are commonly associated with bipolar disorder. So, yeah, I'm going to talk about the causes of bipolar and what it actually says on here. It says, while the causes of bipolar disorder are not clearly understood, both environmental and genetic factors are thought to play a role. Many genes, each with small effects, may contribute to the development within the disorder. Genetic factors account for between 70 to 90% of the risk of developing bipolar disorder. Environmental risks include history of childhood abuse or long-term stress. The condition is classified as bipolar type 1 if there has been at least one manic episode with or without depressive episodes, and bipolar type 2 disorder is if there has been at least one hypomanic episode but no full manic episode and one major depressive episode. If the symptoms are due to drugs or medical problems, they are not diagnosed as bipolar. Other conditions having overlapping symptoms with bipolar can include attention deficit disorder, personality disorders, schizophrenia, and substance abuse disorder, as well as other many medical conditions. Medical testing is not required for diagnosis, but through blood tests or medical imaging can rule out other problems. So, how do you treat bipolar? Well, you have mood stabilizers. They are lithium, and certain anticonvulsants such as valproate and carbamazepine are the mainstay of long-term relapse prevention. Antipsychotics are given during acute manic episodes, as well as in cases where the mood stabilizers are poorly tolerated or ineffective, or where compliance is poor. There is some evidence that psychotherapy improves the course of this disorder. The use of antidepressants in depressive episodes is controversial. They can be effective but have been implicated in triggering manic episodes. However, the treatment of depressive episodes is often difficult. Bipolar disorder occurs in approximately 1% of the general population. In the United States, about 3% are estimated to be affected within some point in their life. Rates appear to be similar in females and males. The most common age at which symptoms begin is at age 25. Around a quarter to a third of people with bipolar have financial, social, or work-related problems due to their long-term illness. Bipolar disorder is among the top 20 causes of disability worldwide, and leads to substantial costs to lifestyle and society. Due to lifestyle choices and side effects of the medications, the risk of death from natural causes such as coronary heart disease or heart attack in people with bipolar is twice that of the general population. Wow, okay. So, yeah, I'm going to go on to the bipolar spectrum. So what is the bipolar spectrum? Bipolar spectrum disorder include bipolar type 1, bipolar type 2, psychothymic disorder, and cases where subthreshold symptoms are found to cause clinically significant impairment or distress. These disorders involve major depressive episodes that alternate with manic or hypomanic episodes, or mixed emotions that feature symptoms of both mood states. The concept of the bipolar spectrum is similar to that of Emil Kreplin's original concept of manic depressive illness. Unipolar hypomania without accompanying depression has been noted within the medical literature. So, what are the criteria? The DSM and ICD characterized bipolar disorder as a spectrum of disorders occurring on a continuum. The DSM-5 and ICD-11 has 3 specific subtypes. Bipolar type 1, which is at least one manic episode, is necessary to make diagnosis. Depressive episodes are common in the vast majority of cases with bipolar disorder 1, but are unnecessary to get a diagnosis. Specifiers such as mild, moderate to severe, and psychotic should be added as applicable to indicate the presentation of cause of the current disorder. Bipolar type 2. No manic episodes and one or more hypomanic episodes and one or more major depressive episodes. Hypomanic episodes do not go to the full extremes of mania, i.e. do not usually cause severe social or occupational impairment and are without psychosis, and this can make bipolar type 2 much more difficult to diagnose, since the hypomanic episodes may simply appear as periods of successful high productivity and reported less frequently than distress and crippling depression. Cyclomania, a history of hypomanic episodes with periods of depression that do not meet the criteria for the major depressive episode. So, yeah, then I'm going to move on and talk about the rapid cycling. So it says, for most people who meet the criteria for bipolar, experience a number of episodes on average 0.4 to 0.7 per year, lasting 3 to 6 months. Rapid cycling, however, is a course specifier that may be applied to a bipolar subtype. It is defined as having 4 or more mood disturbance episodes within a 1 year span. Rapid cycling is usually temporary, but it's a common amongst people with bipolar. It affects between 25.8% and 45.3% of them at some point in their lives. These episodes are separated from each other by remission, partial or full, for at least 2 months, or a switch in mood polarity, i.e. from a depressive to a manic episode or vice versa. The definition of rapid cycling most frequently cited in the literature, including the DSM-5 and ICD-11, is that of Dunner and Feeve. At least 4 major depressive, manic, hypomanic, or mixed episodes during a 12-month period. The literature examining the pharmacological treatment of rapid cycling is sparse, and there is no clear consensus with respect to pharmacological management. Yeah, so I'm going to scan down because some of this isn't relevant. The aim of management is to treat acute episodes safely with medication and work with the patient in long-term maintenance to prevent further episodes and optimize function using a combination of pharmacological and psychotherapeutic techniques. Hospitalization may be required, especially with the manic episodes presented in bipolar 1. This can be voluntary or local legislation permitting involuntary. Long-term inpatient stays are now less common due to deinstitutionalization, even though this still can occur. Following or leaving a hospital admission, support services are available and can include drop-in centres, visits from members of a community mental health team, or an assertive community treatment program, supported employment, patient-led support groups, and intensive outpatient programs. This is sometimes referred to as a partial inpatient program. So, yeah, I just wanted to kind of talk to you about bipolar, and I'm going to scan down and briefly touch, like I said earlier, on medications. Medications can often differ on what episode is being treated. The medication with the best overall evidence is lithium, which is an effective treatment for the acute manic episodes, preventing relapse and bipolar depression, which I'll link about more down below in the video description. Lithium reduces the risk of suicide, self-harm, and death in people with bipolar. Antipsychotics and mood stabilizers used together are quicker and more effective at treating mania than any other class of drug used alone. Some analysis indicates antipsychotics alone are more or less effective at treating acute mania. Mood stabilizers are used for long-term maintenance but have not been demonstrated the ability to quickly treat acute bipolar depression. It is unclear if ketamine, a general dissociative anesthetic used in surgery, is successful in treating bipolar disorder. So yeah, I will link this in my video description below. I hope this has kind of helped you understand what bipolar and depression is. And I just want to say how I'm proud to support people with bipolar disorder. I'm proud to know individuals that do live with it successfully, and they live with it independently. They do function every day. They go out and live their lives to their best ability. I'm proud to be a best friend to one of them and a daughter to the other. And I hope that you guys understand not to treat them for the label, but treat them as the person, get to know them, understand the disability, do your research like I have, and just make sure you're there to support them, listen to them, be their ears and eyes, and just be there to be their friend, their family. Be there and don't judge them, because they go through a lot more difficult times than a lot of us do. And I just wanted to let you know what bipolar was, so please like, comment, share and subscribe. I'll see you next time. Bye!